This is Jeffrey Tucker. Today on the Brownstone Show, I'm very pleased to host Dr. David Bell, who's been leading a Brownstone supported effort called REPPARE. And the point of REPPARE is to look carefully at the operations and functioning of the World Health Organization, especially in light of the COVID fiasco. And it's one of the few research groups in the world that's done a detailed, and I guess you would say academic, investigations of the World Health Organization. I'm cautious to say academic because these days nobody respects anything coming out of academia. So we probably need a better word than that, maybe scholarly or just detailed and knowledgeable looks. Something along those lines. They've been published in journals all over the world. REPPARE has, and it's one of the few organizations that's taking a look at the operations of the World Health Organization, particularly its pandemic planning side, with independence and expertise. And that makes it highly unusual because most people who are writing about the subject, as it turns out, are conflicted. They're part of the pandemic planning industry or otherwise hooked into the gigantic world empire that's maybe not funded directly by the World Health Organization, but is in some sense part of this larger system. So why does it matter? People will often say to me, "Who cares about the WHO? They don't have any enforcement power anyway. The U.S. has left the World Health Organization." But if you recall, back during the COVID period, there was a strange fuzziness about all the mandates and edicts that were coming down in your local community. The stores would enforce the masks by virtue of a town order. You would go to the town and say, "Why do you have this ridiculous order?" They'll say, "Well, the county health department said to do this." You go to the county health department, they refer you to the state health department. State health department refers you to the CDC, which in turn refers to the World Health Organization. So who in this chain was actually bearing any responsibility for the outcomes of these policies? I mean, the fact is that nobody was. That it was a giant, I guess you would say, like CYA operation. Everybody was hiding behind somebody else to do the thing that they knew that would keep them out of trouble. And it all ended up at the WHO. At some point, you might recall, the censorship mavens over at YouTube said that they would not allow any opinions to appear in the whole of YouTube universe that contradicted what the World Health Organization was saying. They made this a policy, and it remained a policy for a very long time. The World Health Organization itself was changing its policies all the time. There was a brief moment in time when the website changed the definition of herd immunity, a long-standing definition of herd immunity that referred to the transmission rate of a pathogen and how to get it below 1, and they are not below 1, signaling the arrival of herd immunity, meaning that enough people are protected against a certain disease so that those who were unprotected were not actually under threat. And that is what herd immunity amounts to. And traditionally, the website said that there are two ways to get there, or that it's a combination of both: exposure and vaccine-induced immune response. Well, the website one day just changed to eliminate the possibility of exposure. In fact, it ruled it out and said you get there not through exposure, but through vaccination. That's what it said. There was a big outcry about that, and it was changed back some weeks later. In any case, the pandemic planning of the World Health Organization had a lot of responsibility for what took place in those years. Hardly anybody mentions the fact that in the middle of February, the World Health Organization arrived with a delegation in Wuhan, carrying with it some representatives of the National Institutes of Health in the U.S. and were sent on a junket around the country to show how beautifully the CCP was able to lock down and control SARS-CoV-2 through extreme measures. And the U.S. delegation came back having written a huge report celebrating how wonderfully China performed. And I once asked somebody who was involved in all this as a very close observer, how significant was that report coming out of that Wuhan junket, in which NIH and Fauci's own staff participated. And he said it was decisive. It was the turning point. Once WHO said the CCP had it right through lockdowns, then that's what triggered everything else. I mean, maybe it was already in the works, but anyway, I'm talking about, let's just say February 18th or so, 2020. And by the 26th and 27th and 28th, Fauci was echoing this report, and then the whole world just completely fell apart. So it's true that the World Health Organization has lost a lot of credibility in the meantime, rightly so, and the U.S. has pulled out. Nonetheless, it still has an important role to play. At the same time, it no longer has the credibility to play it. So I'm very pleased to welcome to our podcast Dr. David Bell. So thank you so much for being here, David.
Thank you, Jeffrey.
Now, what did you think about my summary there of what REPPARE is doing and the role of the World Health Organization? Do you want to add to it or correct it in any way?
Yeah, it was a good summary. And yeah, I would say, so I'm co-leading the project with Professor Garrett Brown at the University of Leeds. And I think it's important to stress it's a University of Leeds project funded by Brownstone. That Brownstone has been extremely important in providing funding, but essentially no guidance, no restrictions, short of a requirement that we publish. We put everything online, openly available, anything we find. So it's an academic project, a university project that with a generous funder who's putting no restrictions and no requirements or no direction, but letting the data take us where it takes us, which is somewhat rare in some ways in academia now, but how academia should operate.
Yeah, let me just make a comment about that, because I obviously, being the president of the funding organization behind it, am in a position somehow to direct it. But the whole thing is ridiculous because, if I knew what REPPARE was supposed to do in advance, then there would be no reason to have the group. The whole point of the group is to be investigative and to take a direction on its own. So that's why Brownstone has been completely hands off. And it is apparently, Garrett Brown mentioned this to me, that this is highly unusual, that most funded research teams in universities come with very specific outcome related instructions and things like that. And this is the burden that almost all scholars at the university level are faced with on an ongoing basis, which I guess I didn't know that, but it seems absurd to me.
No, and I think that sort of leads into my other comment I was going to make about your entry with the WHO. And you give the impression that the WHO is directing this. In a way, I don't think it is. But to explain that, we need to discuss what the WHO is and what it's supposed to be. And most people see the WHO as a independent expert group sponsored by the countries of the world under the UN auspices to, do good, improve health equality, etc. And that's what it was set up for. And initially it had core funding, which means countries give money to the WHO. The WHO, through its expertise looking at disease burdens, at what is redeemable and what isn't in terms of improving outcomes, looking at the science on what improves longevity, which essentially is better sanitation, better living conditions, better nutrition. Antibiotics are important, access to basic antibiotics. Vaccines have had some impact, particularly probably in lower income countries where the other, sanitation, nutrition, etc., are poorer. But it was set up to play that role. What has happened it is a completely different organization now. So the organization that was giving instructions during COVID is really nothing to do with the WHO of 30 or 40 years ago. And it wasn't a sudden change. Even in 2019, it put out the recommendations for pandemic influenza, which said specifically, essentially, do not lock down, do not close borders, do not do contact tracing once an outbreak is established, etc., because these are either useless and or harmful. And that this was accepted, and there's a very good basis for it being accepted orthodox public health. What changed, and there is a stream of thought next to that, which became dominant at the start of COVID, which led WHO to say lockdown, and that was that it's this health securitization agenda where it's all about emergencies. You have a fire brigade that rushes in, concentrates on that problem at the exclusion of all others. So we hear this whole of government approach, whole of society approach, which is the opposite of good public health, because good public health is looking at overall outcomes, not at how do we fix a specific virus that we've just found somewhere. So, but the reason for the change, and it really became apparent, it developed over 20 years, became apparent during COVID, is that the WHO now, 80% of its funding is specified. And what that means is not core funding where the WHO decides, is specified funding, which means the donor, the funder, tells the WHO what to do with their money. So most of the WHO's work now is essentially work for hire. And since the US pulled out, the largest donor is private. It's the Gates Foundation, the largest individual donor. So probably all in all about 20% of WHO funding if you include indirect funding from Gates. But the private sector funding is quite new. It used to be very, very small. Now it's a major part, not the majority, but a major part of WHO's funding. The other major funders, there's Gavi, there's the World Bank, there's EU, so they're not even countries. And then you get to countries and they're dominated by countries with a large pharma, biotech industry. So what inevitably has happened with this change to specified funding is that the WHO has to concentrate on what its funders want. Those funders are very interested. There's also corporate funders are very interested in commodities, particularly vaccines, because you can make a lot of money from these. And also you can tick a box and say, we gave out 20 million vaccines, therefore let's pretend we saved 1 million children's lives, versus we improved nutrition over 12 countries in sub-Saharan Africa, and in 20 years' time we'll notice that people are living 10 years longer. That would be a better outcome. But it's not exciting, it's not going to get in the media, it's not going to excite politicians, and it's not going to bring return on investment for the funders of corporations. And besides the WHO, over this 2 decades, we've seen a rise in public-private partnerships. And I was in WHO when this started, essentially. And it seemed, people thought it was a good idea. Private sector would bring their expertise, their, more focus than the sort of the global health bureaucracy. And they would bring more money, and surely that would save more lives. But what people forgot or thought they could control but obviously couldn't is that a private company only gives money if that money is going to bring return on investment for its investors and for its executives, because that is their role. the role of a private company, the role of Pfizer, the role of Microsoft is to make money for its investors. It's not there to be an altruistic agency for the good of people in Burkina Faso or Texas or Vietnam. So they're there to make money out of those people. So they can really only take part in these public-private partnerships and in the WHO if it's going to do that. So this has led to this increase in commoditization. Now, instead of improving nutrition, improving sanitation, we manufacture something and stick that into people. And it's not as good because it'll only fix the specific thing, like SARS-CoV-2 virus, that person might be susceptible to. It's not going to do anything for the rest of their health, and it may have harmful side effects. But it ticks a box and it returns a profit. So, these entities, and particularly, the Gates Foundation is prominent because there is so much money. And the money from the Gates Foundation has saved lives. It's saved lives in malaria, in TB, etc. But so this isn't simple. But it has also funded the schools where the people in WHO, the staff are trained, the global health schools, public health schools. It funds the modelers who know that if they don't deliver useful results, then they won't get more funding, obviously. It funds the research groups who will research what the funder was interested in and not something they're not interested in because they need to be refunded. There are direct partnerships with journals such as The Lancet, which has a very close relationship with the Gates Foundation, IHRP, University of Washington, etc. So they will publish what is beneficial to that relationship because The Lancet, like all journals, or almost all journals, is primarily a for-profit business owned by much larger publishing companies that are owned by an even larger publishing company that are owned, the majority shareholders in Lancet, I think, are in the end, if you go high enough, Vanguard and BlackRock, like Pfizer, and like most media outlets, same ownership. So global health, international public health, has become, over these few decades, a vehicle to improve return on investment for very large international corporations. And they have done what they have to do as a corporation, which is do what is needed to maximize that return on investment. And as we've developed these commodities, as biotech is advanced, etc., that has become get these things, these profitable things that they have IP on, into this massive market of billions of people around the rest of the world. The WHO and the public-private partnerships that have arisen, like Gavi and CEPI, are the ideal vehicle to do that. So they have used them and they're using them. So we have to understand now the WHO is no longer an independent agency, therefore the good of population health. It's an agency predominantly directed by certain funders, which are or are heavily influenced by corporate healthcare commodity manufacturers, to do what those manufacturers need for their purpose, which is maximizing their profit. And the whole industry, the staff, etc., built around that, they're being indoctrinated through the colleges, but they know they're very dependent on pleasing these funders in order to keep them and those under them employed.
Just to be clear on the implications between this sort of commodity distribution model of health and the recommendation that the World Health Organization had made concerning lockdowns, I wanted to just draw attention to this because it took me the better part of 2 years following the beginning of the lockdowns to see the connection between the stay-home orders and the policies and the business closures and the school closures and the travel restrictions and everything else, and the eventual distribution of the inoculation. I had a blind spot that prevented me from seeing that these were necessarily related. I thought that something had gone haywire in the minds of these sort of uh, pandemic planners, that they thought that if everybody just sort of hid under their sofa, that the virus would somehow magically go away, or the R naught would drop down to the point that nobody was under threat anymore, that we could all just come out and be happy again. But it became pretty apparent, it should have been obvious fairly early on, that the whole purpose was the distribution of the vaccine.
I think so, yes. And not just that vaccine, but to put in place the model, which is there now and is being funded now, to repeat this over and over again. So we have the 100-day vaccine program at CEPI, which is a public-private partnership in Geneva. So this is funded mostly through these, or it's a public-private partnership. So it's funded through public money predominantly, but with a large private sector input. And so and then the profits go to the private sector. So the public money is going to support manufacturers to have these production lines ready so that at the drop of a hat, they can produce another mRNA vaccine. And lockdowns and then freedom from get your freedom back by being injected is an extremely compelling business proposition for any pharma company to be involved in. So I think to me it didn't make sense either. I'm a public health physician. I've worked on outbreaks. I worked on the first SARS outbreak. It was very clear early on, and was published in Lancet by Imperial College of all places, that in China, COVID was killing old people. It was almost not at all killing children or working age healthy people. So we knew that in March. So there was, we knew in February. So there's never a justification for locking down, for doing any extreme measures towards children, towards working age adults. We know, and it's obvious, that if you make people unemployed and you put the increased poverty, then life expectancy goes down. And there's a number of reasons for that, not just having enough money to access healthcare. And that's very well established in public health. And this is why WHO had previously said you don't do these things, because there's a very close relationship between economics and health outcomes. And so when we did what we did in lockdown society, closed supply lines, put millions of people into unemployment, etc., and borrowed money, which pushes this to the future to fund incentive payments, etc., then we knew that we were lowering life expectancy from what it would otherwise be in the future. So that was done for a purpose, and I think that was done because in the end, the drivers of this that are not WHO, but it's just this whole industry, healthcare, essentially healthcare commodities industry, and those who own that. Their interest was in putting the mindset in place in people that outbreaks are an existential threat, and we need to take their commodity and pay for it in order to keep society functioning and survive ourselves. So that was never the case during COVID. It was dangerous to people who were heavily overweight, had other severe chronic illnesses that were going to greatly shorten their life anyway, and was very rarely dangerous to anyone else. But, we did not hear that in the media. The media, again, are controlled by in the end, by the same financial houses and so on that control pharma, that control indirectly WHO and the health agencies.
It's quite an extraordinary gamble, though. It strikes me because just looking back at it, I get that. Okay, you profit from the distribution of this shot to billions of people. Okay, you can bank that money, but I mean, it should have been. I mean, if it was apparent to me, it had to have been apparent to many other people that there is no such thing as a vaccine in a traditional sense for a respiratory virus that's fast mutating that also has a zoonotic reservoir. There's no product in the world that can.
Yeah, there's no effective vaccine. You can make a vaccine; it's not going to work very well. Yeah,
right. So they distributed an ineffective vaccine that also turns out to be, from all the records we have, probably the most dangerous.
It's intrinsically dangerous, mRNA. Yeah. It doesn't mean you should never use it, but there are intrinsic dangers because it reprograms cells to produce a protein that the body recognizes as foreign, and they kill that cell, and they cause inflammation, kill the surrounding cells, and we cannot control the dose with mRNA. So, it's the sort of thing that we would never, ever, I've been involved in studies and in pushing out new products and so on, and the difficulty of getting anything to pregnant women because of the inherent risks and extreme care that we all take, that was completely washed away in COVID. The idea of giving something to a pregnant woman that we knew, because the way it's packaged in the lipid nanoparticle, will cross the placenta and will enter the cells of the fetus. And we know that it concentrates in certain organs such as the ovaries, the liver, the adrenal glands. So critical to the fetus, to its growth and to its future. The idea of giving that, and in a context of the risk to that woman was very low from COVID in the first place, is just, I think the only reason that was done was there was a decision, that a feeling that if you started excluding certain groups, even infants or pregnant women, then people would start thinking, the public would start thinking, is there something a little bit dangerous about this? And the whole push of this was, which is completely unevidenced and against what you could predict from the type of medicine used, was that it was just safe and effective, no harms, end of story, which we never do for any other medicine. It was an absolutely unique. We tested it far less, we tested it far shorter, far less oversight of those tests, and then we pushed it out to people that we would never use a new medicine on for any other purpose, for something that overwhelmingly affects people over 70 who are already ill. It's hard to grasp what was actually done over this period when looking back, but this is what happened, and it's not gone away. COVID is sort of gone from the public's consciousness, but in the global health world, the idea of doing this again is there. The surveillance is being ramped up to find the next natural outbreak that could potentially be used as a threat and therefore lockdown 100-day vaccine. But we're also seeing more and more gain-of-function research, which is almost certainly what COVID originated from, which will do the same thing. It's probably by far the main risk of a future outbreak.
So just to be clear, I mean, I think for a lot of people who are casual observers of this, there's this impression that the whole thing was such a calamity that it would never be undertaken again, and that
it wasn't a calamity. It was a calamity for us, Jeffrey, wasn't it? But this made the largest profits in history for pharma, for a number of large diagnostic companies and others, and much larger than a lot of people realize. I think I know people who work in diagnostics, and I know some of the profits. And there are companies that all their other income went down, but they made the largest profit in their history because just on the back of the COVID tests. So this was a massive success in terms of the people who had the vested interest in making it happen. It was a huge success.
So the existing documents, you're very attentive to what the pandemic planners are saying. You see no evidence of that anyone's learned from mistakes, but quite the reverse. That there's every indication of high level intentions to double down on this model of lockdown until you can vaccinate.
Yeah, and it's very interesting. We have, from before COVID, we have during COVID, we have the Cochrane Review in 2023, for instance, on masks, saying in the community they don't work. For the first SARS outbreak, I was involved in WHO in drawing up the lists of protective gear, etc., for people who are looking after patients, for their direct families, for their direct contacts, etc. And we included masks, P6 masks, which HEPA masks, which you had to change frequently. There were certain ways to put them on, which avoided cross-contamination, etc. And you wore them for short time change, and it was only for people in direct contact, very close contact, etc. And we would never have recommended them for the wider community because it made no sense. Because the surgical masks don't stop a aerosolized virus anyway and aren't designed to. And unless you change them every 20 minutes, half an hour, and you do that in a certain way, etc., and they're perfectly fitted, they're not going to stop anything from being breathed in or breathed out much. So they were never going to work. They never did work. We have overwhelming evidence, and the Cochrane Review is very thorough. And contrary to what the media told us, it was not withdrawn. There was a very strange going on between a New York Times journalist and a leading editor in Cochrane, but there was not a withdrawal of that study, and no one has questioned seriously the findings. Yet we have the WHO now giving advice, which, if you follow it logically, it would say virtually everyone should wear a mask all day, and older people indoors and outdoors whenever there's a flu outbreak, which is a third of the year. So, it's ludicrous. And we have overwhelming evidence that won't help. We have the global burden of disease, IHME. This is the gold standard for disease burden globally, which is used in public health for determining where you put your resources. They came out over the last couple of years with a number of publications on COVID, and it's basically modeling. It's not solid data, but the model assumes that if a country didn't use masks, the COVID death must be much higher than they said. So it's even going into, that means they end up with about 40 million deaths rather than 7 million deaths for COVID. So then that makes the whole thing worse and justifies the future surveillance, response, etc., which we're seeing. So it's, the problem is extremely deep. It's not a few bits of data. And most of my colleagues, unfortunately, in global health will say masks help, not because they have data on that, but because there is such a push to believe that, just to be comfortable at work, to get a job, to keep your job, and to please the funders who are your lifeblood, or you and your team don't have a job anymore. So it may be out there in the community that these things don't work, but it's not in, unfortunately, the public health world at all.
A remarkable thing. Now, let me ask you about somebody else concerning as we look back at it, it's one thing to distribute a product and say, okay, if you're really scared of COVID, get this shot, okay? And that's fine, whatever. But that's not what actually happened. The pressure was overwhelming. It was ongoing to every single media thing, whether it's newspapers or television or radio, and constant unrelenting statements from the top. And then things got particularly vicious to the point that we began to hear about it. The only reason we have a pandemic is because of the unvaccinated. They're the ones making you sick. It's because of your assertion of your rights to freedom that there's any problems remaining in the world, that everything could be solved. And then I recall that the estimates of what would constitute herd immunity, which, as it turns out, just to be clear, the vaccines made very little, if any, contribution to the obtaining of herd immunity because they didn't stop transmission. Okay, so they didn't stop infection, they didn't stop transmission. So you can't contribute, in a technical sense, to herd immunity in the traditional public health rendering of that term if you don't have a sterilizing shot of some sort. So they're not actually making any contribution, but still, there seemed to be this view that, well, we have to have 60% vaccinated, then 70%, then 80%, and then very late it became like 90%. There's no way they were going to get to that level, and yet that's when the warnings became ever more severe. Well, now is the winter of your discontent, or whatever.
Yeah, winter of death, I think it was. Yeah,
winter of death and suffering, or whatever. With the cemeteries you'll soon overwhelm, or whatever the thing was. I can't remember. But was that in part driven by this? Was it just profiteering? Like, well, let's get as many shots out as we can. Or was it, did they have a target in mind of like, well, we've got to get to 90% or else we're going to continue to be vexed by this terrible disease?
Well, there's people doing modelling that were saying, just assuming it was going to, say, block 90% of transmission, which I had no data for at all. And then they were doing the modelling, and it shows that if you get, say, 75% of the population vaccinated and it stops 95% of transmission, then it'll work to stop transmission overall. And then that modelling will be published in Lancet or something, and it'll get in the BBC and New York Times, and everyone will be reading it, and that's real. But 99% of the people who read it, which is just in the general media, haven't read, and even those who read in the journal don't read it enough to know that this was just an assumption that had no evidence whatsoever. And Fauci was co-authored a paper in, I think it's January 2023, it came out, just pointing out how the vaccine was never going to work because injected vaccines don't produce mucosal immunity with immunoglobulin A in the respiratory tract. And therefore, even though it might work in reducing severe disease and death, it might do that because it'll help stimulate an immune response a bit faster to systemic viremia, etc. But it won't stop infection, replication, and transmission from the respiratory tract. And so Fauci knew that, even though he was saying otherwise. And
that was a dark moment when I saw that paper being done. You said that was January 23. Hardly anybody knows anything. Like nobody remembers this, but yeah, Fauci basically.
It also showed how, to me, in a way, the total arrogance that you can be saying one thing over and over and over again, publish a paper saying the opposite and saying everything you said was wrong, and then just go on, and no one blinks. The CDC also, that while they were saying everyone has to get vaccinated, they were publishing data in their own journal, MMWR, saying, pointing out that post-infection immunity is actually more effective than the vaccine, and this is a big study in the US, and that if you add the vaccine, this sort of hybrid immunity, which is a new term that was invented, it makes no measurable difference, in the real world. So CDC knew and published on the fact that there was no reason whatsoever from a clinical point of view, to put the vaccines into people who'd already had COVID. But they still said so. Yeah.
There's also the very strange fact, and we can make this podcast last for 18 hours if we wanted to, but just
we haven't got on to repair yet. But
we haven't got to repair. But I just want to mention something very quickly that there was. In late 2020, there were a number of seroprevalence studies that were being done that were showing widespread population immunity from exposure. A lot of those studies were stopped once the vaccine came out, because it's like the last thing you want people to know is that we're already obtaining population-wide immunity at a very high level without a vaccine, and those studies were never distributed. I mean, we're not even sure.
Some of them were, though, even published, Jeffrey. I mean, there's a big one that WHO was involved in running and publishing in Africa, which showed, it came out late, I think late 2021, but it was pre-Omicron. It showed 66% of people across a whole lot of regions of Africa, large study, had evidence of COVID infection, serological evidence, which means that a lot more than 2/3 had been infected, because you don't always pick up the antibodies. So this was before, and this is important from a global health point of view, because this was before they pushed out most of the COVAX, this sort of vaccinate the world stuff, which was the most expensive public health program, single public health program per year ever, and was extremely costly in diversion of resources from other programs that actually work. So nutrition funding went down, etc. Malaria control went down and malaria numbers went up, deaths. To vaccinate all these people that the WHO knew were mostly immune already. This is before Omicron went through and hit almost everyone on Earth. So, which Bill Gates, is on record as saying was the best vaccine you could get for that reason. Because, and just to explain perhaps, the vaccine, so the mRNA vaccines, they cause your cells to produce a part of a spike protein of a particular variant, which is, usually because it takes some time to make and distribute. The variants already become relatively rare, and there's a new variant with a slightly different spike protein. So it's not going to have a lot of, it's not going to be perfect for what you're infected with anyway. If you're infected with a virus, you get, in this case, all 4 of the SARS-CoV-2 proteins, and you get the whole protein, and so it forms a much broader immunity. The spike protein, which is the vaccine one, is the one that changes most. The N protein, for instance, is also on the envelope of the virus, so it's in contact with the immune system very early on, and that is much less changeable. So that is why you have to keep producing a new vaccine for every variant. But if you've been infected with the whole virus, you're going to have much better long-term immunity against future variants.
Sure. I mean, it's a universal rule in public health vaccinology, epidemiology, whatever. The natural infection is always going to be more durable, broad, with a greater range of cross immunities than any conceivable vaccine. I mean, that was something that was just a kind of a known doctrine. It was a law of the universe.
With the possible exception of attenuated whole virus vaccines, which, you get the whole virus, but not some of the nastiness. But whenever you inject just a part of a virus or a protein or something, you haven't got as broad immunity as you would otherwise have.
I want to, you said we hadn't talked about repair. And we are running out of time, but I want to talk about repair and I want to talk about IHRP. But one of the studies that came out of repair's work that I most admire, and I admire all of your work, and I don't know how many papers you guys have generated now. It's probably a dozen or so, but the one that takes on this prevailing assumption that we're seeing more and more. I want to use the right language, but I don't quite remember it. But viruses that are leaping from animals to humans. That this is somehow on the increase, and you see this said again and again and again in the literature, and without any attempt to prove it. It's just, well, because of industrialization, deforestation, climate change, too much milling about, or whatever the thing is. We're seeing ever more crossover viruses that are going from animals to humans, and this is a really important part of the theoretical presumption of these industrial players. And why, when SARS-2 appeared, it became very important to Fauci and all these other players out there to assert that this was a zoonotic origin and not a lab origin. Because if they had prevailed on that assertion, it would have reaffirmed this idea that we should all be more panicked than ever about the bird flu, about the parrot flu, about God knows what, right? Everything. So repair actually, one of the few papers I've ever seen that actually took this on empirically and discovered that it's simply not the case.
Mm. Yeah, and I think it's worth mentioning here, repair is not concentrated on COVID. We've been talking about COVID. Repair is looking at the pandemic agenda in general and sort of looking forward. And so, and we've been looking at the main publications of WHO, World Bank, G20, etc. on this, and published papers, and assessing how well their evidence stands up and their claims of return on investment, etc. Because this is tens of billions of dollars a year that is taxpayers' money that's going into this. So as you say, a critical part of this is this claim that pandemics are increasing. The risk of pandemics is increasing, outbreaks increasing, and therefore there is, quote unquote, from the G20, I think, an existential threat to humankind. And this is what our leaders are being told. It's what our politicians are being told, our governments, by these agencies that they generally trust. So it's interesting. There is an increase, a rapid increase, up to about 2010 or so, from about 1960, in the number of recorded outbreaks of disease. And it starts off particularly in North America and Europe, and in China through the 1970s, 80s. And then that sort of flattens out at a high level, and suddenly there's an increase in sub-Saharan Africa and South America and South Asia. And surprise, surprise, this completely mimics the rollout, the invention, development, rollout of diagnostic tests, the technology we use to distinguish an outbreak or a pathogen from the background. So in 1960, we had microscopes, and that's about it. And now we have point-of-care antigen tests, point-of-care serology tests. We have PCR, which was invented in 1983, which is the main way we distinguish between one virus and another. And we have gene sequencing, which is how we work out, is this a new variant of SARS-CoV-2 or not, etc. And then we've developed digital technologies. We've developed roads so that we can have more clinics and telephone lines. And then we turned them into cell phones and then computers and the internet and Starlink. And we've put lots of money into this. So surprise, surprise, we're now able to distinguish a new variant of influenza from all the background of infectious disease. Yeah, Nipah virus in Malaysia is an interesting one. It looks just like Japanese encephalitis. If you look at, it's in bats across Asia and Africa. The outbreaks are nearly all. There's that one in Malaysia that was famous in about 1989 or so, and then there are outbreaks in India, around in Bangladesh, in the northeast of India, and in southwest India, around Kerala. And they are recurrent, and there's about 30 to 100 people might die in a bad outbreak. And they look like Japanese encephalitis. We know it's Nipah virus now because we have the PCR and the gene sequencing, and we're looking for it. But they've almost certainly happened, probably for thousands of years, at about the same rate. And we didn't know because it's just some people die of a fever and a bit of encephalitis, which is not that uncommon, and it's another death. And now we're not seeing more death, and outbreak deaths have gone down per capita over the last 30 or 40 years. And this is very good data showing this. But the number of outbreaks we distinguish one from another has gone up. But interestingly, since 2010, based on the Gideon database, which is the largest database that everyone, all these agencies use, there's actually been a drop-off even in the number of recorded outbreaks. So that probably reflects that we have sort of reached saturation with, surveillance. And now we are seeing just the inevitable improvement in human health. The infectious disease mortality overall has steadily declined for the last 150 years and is continuing to do so. It's a bit of a blip in excess mortality during COVID. That took us all the way back to 2010 levels. So almost nothing, yeah. So there's this steady, inexorable decline in infectious disease deaths. Almost certainly the same influences are reducing mortality and frequency of outbreaks, but we have developed an ability to distinguish them from background. And this is apparently, although it's completely obvious to all of your listeners, it's lost on the WHO, the World Bank, the G20, and our governments in all their publications. So none of them go into this, even though it's undoubtedly a very, very major factor, if not the major and possibly the sole factor in this increase.
The reason why infectious disease has declined over 150 years, cleaner water, better hygiene, wider exposure leading to broader immunity.
Yeah, yes. So increased travel probably improves things overall because we don't have these like American Indian populations. There's a massive population that had no exposure for dozens of generations to these diseases. So smallpox, measles, etc. is devastating. Same in the Pacific Islands, Australia. And antibiotics have had an impact. So if you go to a cemetery and you look at the graves, the old graves, there's lots of children died up to about 1920 to 30. It was common for children to die. Now it's very rare. And that was because of, a lot of these childhood illnesses. But what we don't know is how much was antibiotics and how much was just a steady improvement in outcomes. So, things we had no antibiotics for, like measles. Most measles death went away. It was quite devastating. 1890s, 1880s, there was very little death going on when we introduced mass vaccination in the 1970s because most death had gone away. Measles was still prevalent. Every kid got measles, but they weren't dying from it anymore. So, and that's not antibiotics. That's just, as you said, better nutrition, better living conditions, better
Better diet.
etc. So, yeah, better diet, and particularly, most measles death happens in children who are malnourished, particularly vitamin A deficient. That's not controversial. The WHO used to and still does recommend vitamin A in measles outbreaks for that reason.
Yeah, when RFK said that, that resulted in screaming shock.
Yeah, I had friends of mine screaming, "Isn't he ridiculous?" No, he's not. He's following WHO recommendations.
Yeah. Yeah,
which in this case were actually evidence-based.
So, REPPARE is another year of life, and many other papers, I'm sure, are in the hopper there. And then, but now we are. It's been very behind the scenes, but working on a model for nations to still guard their particular public health needs, disease monitoring and mitigation and so on, while stepping away from a dependency on World Health Organization recommendations and data. And this is called the International Health Reform Project, which I think, if am I right that we're on track to start distributing material on that maybe in February and March this year?
In March, yeah. So, yes, and again, this is funded by Brownstone, but it's an international panel with experience in the UN, in WHO, in academia, in international law and public health, etc., in clinical medicine, from backgrounds in Asia, North America, Europe, and Africa. And I'll comment again that because it's important to state, Brownstone hasn't influenced in any way the direction of this panel. You've given us the funding, and we have independently worked on this. And I think that we've got to put out 2 long reports, a policy report and a technical report. And the approach we're taking, very briefly, is going back to the basic ethics and principles of public health, the drivers to improve longevity, and the ethics of medicine and the governance of medicine, public health, from the Hippocratic Oath to the idea of bodily autonomy, etc., and then how that translates into a public health context where you're dealing with populations rather than individuals. But it has to be based on individual sovereignty, essentially, and to some extent national sovereignty, where that is an expression of individual sovereignty within, you have a government which hopefully you can influence. So I think it's clear that there are a lot of advantages in having an international health organization. And that includes things which people understand, like malaria, tuberculosis, HIV in low-income countries, where harmonization of effort and research and also support funding is important. Capacity building of countries so that they no longer need support is extremely important, and helping to build that capacity so that they're self-sustaining. And this is reflected in part of the recent United States new global health strategy. They emphasize capacity building. It used to be what the primary goal of the WHO. And to do this, you need a very decentralized organization that is influenced by the countries, not by private industry. They essentially can't take private money, because inevitably private money only comes with influences which are not necessarily those of the population it's supposed to serve. And it cannot clearly tell people what to do. I mean, it's unethical. If you go back to the Nuremberg Declarations and Declarations of Helsinki and so on, and the understanding of human rights after World War II, it was in the end that a person can make their own decisions on their own body and their own life. And that's not, you can't abrogate that. So any public health policy needs to be built on that basis, which essentially means you can't have an organization telling everyone what they can and cannot do and what they will be injected with and what they won't. And you can't coerce them to that. So on that basis, you can develop a public health policy which is much more effective than now, which concentrates on these, primarily on capacity building so that countries are independent, and on these main determinants of health that you mentioned, nutrition, etc. If you improve nutrition, you improve measles outcomes and malaria outcomes and tuberculosis outcomes and schistosomiasis outcomes and everything else. And you make that person able to attend school better, be better educated, contribute more to the economy so that the next generation is much healthier. So that is where we should be concentrating, and not, whereas WHO has been heading in the direction of just being, and is talked about as a good thing, a firefighting organization that will rush to the next outbreak and put out the fire. That's not what people die from. Almost all mortality in the world is from very different things. And in terms of infectious diseases, from these, these major diseases that by and large are completely stoppable, and they're a result of poor economies and poor health services, and which are very much influenced by the resilience of the person in terms of how well they're fed, their sanitation, etc., their environment. So that is where you get the gains in health outcomes.
So it's kind of remarkable as you're talking. I'm realizing IHRP finds itself in an awkward position of rebuilding the whole of what our understanding is of public health from maybe a century, from what it was a century ago, and then having seen the lost track of these principles.
It's what it was 40 or 50 years ago. It's not that long, yes, and that's important because it's orthodox public health. It's evidence-based public health. It's the public health that doesn't come out of the mouths of Pfizer, but comes out of the mouths of years of experience and thorough studies of evidence. And that everyone used to be taught and everyone used to essentially agree with in public health, until the influence of money and funding and the need to keep your salary and to fund your staff changed that.
Yeah. Well, we look forward to the IHRP and to REPPARE. How many more papers do you have in waiting for acceptance at this point?
Waiting for acceptance, we have 3 or 4 at the moment. It's been difficult. To get stuff published, as you know, Jeffrey.
Yeah.
If you show, and it's interesting, it's because we have one at the moment. I won't say exactly what it is, because we're resubmitting again. But it questions a major gold standard in global health, and we have been through a few journals so far, and not one review has questioned the correctness of what we are stating. But we cannot get a journal to publish it because the journal has nothing to gain, unfortunately, in being truthful and upsetting the apple cart, because they are, in the end, they are businesses there to make a profit, and they need to please the people who have the money, and this is what people most need to understand about public health and global health now, that it is about profit primarily and about people keeping their jobs. And if you understand that, then you can sift through what you're being told and figure out what's likely to be true and what is not.
Yeah, it's and there that through that one lens you can understand the deprecation of natural infection, the neglect of things like nutrition and clean water and personal hygiene and these kinds of things. That's not where the money is.
Yeah, and I don't think you need to build a sort of a nefarious cartel just trying to destroy the world. In the end, it's an inevitable corollary of, you have these huge multinational corporations and financial houses like BlackRock, Vanguard, and so on that are the main shareholders in them all. And they also own the media. They also own these other assets. And you take away the regulatory thoroughness by allowing your regulatory agencies to be funded by the same people as they are now, then this is inevitable. It's always going to happen. It's why we didn't allow regulatory agencies to be funded by the people they're regulating in the past, why we had conflict of interest rules once, because this is inevitable human behavior.
Yeah. Yeah. Well, David, thank you. We look forward to these IHRP things where I think Brownstone's intention is to publish them in book form when the time comes. So thank you so much for your wonderful work and for joining me today.
Thanks, Jeffrey.